Okay, so I'm actually improving in OB-GYN. I feel that. I feel like I'm understanding a lot of stuff that I had no idea about before. So what I'm gonna do is that I'm gonna solve the. I already had a block. Like, imagine I feel better, even though I didn't even like get into the real stuff. So I didn't even get into the like the cesarean delivery and all that stuff. So I'm pretty sure when I finish like Kaplan, I'm gonna feel way better. So that's really good. Okay. Which of the following is this patient most at risk for? Okay, what does this patient has? Sterile speculum shows an absent cervix, a blind-ended vaginal pouch. Okay, so we have two options. Either complete androgen insensitivity syndrome or Mullerian agenesis. Okay, so if it's Mullerian agenesis, it's going to be this. It's gotta be like pubic hair standard stage 5. Yeah, that's Mullerian agenesis because pubic hair is normal. So there's gonna be urologic anomalies which is associated with Mullerian agenesis. Okay, that's good. That's pretty good. Okay, moving on. Which of the following therapies is the most appropriate next step in management of this patient? All right. Okay. Intramuscular betamethasone and intravenous penicillin are administered. So she's probably giving birth. We're giving her, she's pre-ROM or P-PROM. 39-year-old woman, gravida 1, paro 0, 3 hours of painful contractions. She's in labor, right? The patient's pregnancy was complicated by first trimester. Vaginal bleeding. Ooh, okay. Loop electrosurgical excision procedure several years ago due to abnormal pap smear. Digital cervix examination shows the cervix to be 3 centimeter dilated and 80% effaced. So the guy's in cephalic presentation. All right. Okay. I mean, 80% effaced and 3. This is very small dilation. She gotta dilate even more. So I think we're just gonna give her. She's 34 weeks, so no need for magnesium sulfate. Labetalol. That's like given for hypertension. Indomethacin. What are we trying to do? Are we trying to just like inhibit the? Oh wait, she's 34. Maybe nifedipine to stop the labor, like tocolytic agent. I think I got a question like this wrong before. 39-year-old, 34 weeks gestation, 3 hours of painful contractions. The patient first trimester bleeding. Yeah, probably just gotta. Yeah, we just gotta stop the contractions. Well, let's see. So, first of all, the way I got this question right is this 3 centimeter is very low. It's very small for 80% effaced. That's like I solved a lot of questions and I saw this is not the truth. So let's see. This patient at 34 weeks. Regular painful uterine contractions and cervix that is dilated 3 centimeter and 80% effaced. This presentation is consistent with preterm labor. Okay, this is diagnosed with preterm labor. Regular uterine contractions and cervical dilation and effacement before 37 weeks. The management of preterm labor involves interventions aimed at decreasing the risk of complications of preterm delivery. Preterm birth is associated with complications such as sepsis. Why sepsis? Cerebral palsy, cognitive, visual, and hearing impairment, necrotizing enterocolitis, respiratory distress syndrome, bronchopulmonary dysplasia. Oh my god, all that. Okay, let's see the video about preterm labor, I guess. Okay, let's write down the important cases. Preterm labor. Patients in preterm labor more than 32 weeks are administered antenatal corticosteroids to decrease the risk of ARDS and antibiotics against group B strep, typically penicillin. Finding the tocolysis, the administration of inhibition may temporarily prolong pregnancy, allowing for further fetal maturation in utero and completion of the course of corticosteroids. Okay. At 32 to 34 weeks, we use nifedipine. 32 to 34 weeks, we use nifedipine to just stop the preterm labor. We use nifedipine to stop the preterm labor. Okay, that's fine. Okay, again, so occurs less than 37 weeks, regular painful uterine contraction every less than 5 minutes. Okay, evidence of cervical change more than or equal to 3 centimeter dilation, cervical length less than 20 millimeter of transvaginal ultrasound. So you give antenatal corticosteroids, you give group B strep prophylaxis, so intrapartum penicillin, and magnesium sulfate less than 32. So we don't want to give that because she is more than indomethacin less than 32 weeks and nifedipine 32. Alright, so we have two options. Indomethacin if it's less than 32 weeks, or nifedipine. Indomethacin or nifedipine. Indomethacin or nifedipine. Okay. Which of the following is the most appropriate next step in management? Something is vibrating. Is that my phone? One second. Alright, so let's see this one. Which of the following is the most appropriate next step in management? Alright, so 33-year-old woman. She has anxiety and irritability over the past year. 10 days before the menses, she goes from feeling fine to feeling awful. She has frequent angry outbursts, severe breast tenderness, resolve after the start of her menses, and she feels fine. She feels the okay, spironolactone, I mean diuretic, you would give her diuretic. That doesn't sound right. Progesterone, like, no. Ibuprofen, No, she's like mentally ill. Alprazolam is given for anxiety. I think it's just fluoxetine. That's like post. What is it called? Dysmorphic disorder. Yeah. Wow, I'm getting questions right, bro. That's good. Yeah, premenstrual syndrome. Premenstrual syndrome is characterized by the presence of physical symptoms, bloating, fatigue, breast tenderness, behavioral symptoms, mood swings, irritability, anxiety, depression, which occur during the second half of the menstrual cycle and interferes with the patient life. PMDD, yeah, that's these are the letters I'm looking for. Yeah, bro, bipolar. PMDD refers to the most severe form of PMS and is characterized by predominance of anger and irritability. Okay, that's a pretty easy question, to be honest. It's just I don't remember what is the treatment for. So you give SRI. I think the first line was like the first line treatment was like psychotherapy, I guess. We just give her fluoxetine. I don't know. Okay. Which of the following is the most appropriate next step? All right, let's see the physical examination. All right, let's see the speculum exam. Physical examination shows non-tender and slightly distended abdomen. She's pregnant, right? Okay. Speculum exam shows scanned blood in the vagina. Bimanual pelvic exam shows a non-tender 10-week size mobile uterus and bilateral adnexal masses. Ultrasound shows a 5 centimeter. Okay, I feel like this is fecal lutein cyst. Mohammad Nazar. Hi, bro. I think this is fecal lutein cyst. Ultrasound shows 5 centimeter heterogeneous mass in the endometrial cavity and bilateral multiseptated cystic adnexal mass. Oh, yeah. Okay, so she had uncomplicated term vaginal delivery 14 weeks ago. Uncomplicated term vaginal delivery 14 weeks ago. Right? So she delivered. Does she have fever? No, she doesn't have fever. Okay, this is molar pregnancy, but what I don't understand is that she delivered 14 weeks ago, uncomplicated vaginal delivery, and then she had these symptoms: non-tender, slightly distended abdomen, scan blood. Yeah, I think just surgical evacuation, antibiotics. I don't think you're gonna observe, bro. Don't think you're gonna observe. Oh, choriocarcinoma. Damn, I forgot. Choriocarcinoma. Yeah, I thought, okay, so surgical evacuation, antibiotics. I mean, antibiotics would be like if you have retained products of conception, but she doesn't have fever, so this is not infection. Why would you give antibiotics? Chest radiograph, because choriocarcinoma goes to the lungs. But is that the first step of management? That's weird, bro. That is weird. Yeah, retained placental tissue that can present with abnormal uterine bleeding and intrauterine mass. However, there is no association with thecolatine cysts. So I got the diagnosis right, but next step, no. Nausea, bloating, abnormal uterine bleeding, gestational trophoblastic disease. Is that the first step though? To like do a chest radiograph? Right. Treatment: surgical resection, followed by chemotherapy, typically with methotrexate. Okay. I mean, that's fine. Which of the following is the most likely diagnosis? Pelvic ultrasound shows a normal uterus and no adnexal masses. Normal uterus, no adnexal masses. Okay. Speculum examination shows the vaginal mucosa to be pale and covered in petechiae. Alright. Painful urination, pain. What is that? This is strawberry. This is strawberry cervix. So this is trichomonas, isn't it? Alright, let's see. To be pale and covered. Your analysis shows 50 to 100 leukocytes and 5 to 10 erythrocytes. Pelvic ultrasound shows normal uterus, no adnexal masses. "67-year-old. I mean, that's just signs of menopause. Oh, the vaginal mucosa is what's covered. Oh shit. What's covered in petechiae. Right, that's not the cervix. My bad. Alright, is this Candida? No, there is no like itching. And there's no discharge, white discharge. Is that endometrial carcinoma? Urination, painful urination. No, these are not the symptoms of painful endometrial carcinoma. Genitourinary syndrome of menopause. Okay. So we have leukocytes here. We have evidence of infection. Interstitial cystitis, bladder pain syndrome. Vulvar lichen sclerosis. No, this would present with vulvar lesion. There's no vulvar lesions here. The vaginal mucosa is just a problem. Perineal examination shows a resorption of labia minora and loss of elasticity. So no. How do you manage to stay so long? Actually, I took a nap. I didn't stay for so long. So I took a nap, then I woke up and I'm doing the questions now. But it's fun to me, so solving questions is fun to me. Pelvic ultrasound shows a normal uterus. Alright. Interstitial cystitis, bladder pain syndrome. Okay, what is she complaining about? She's just complaining about frequent urination, frequent painful urination, pain during intercourse, post-coital spotting. If she has interstitial cystitis, bladder pain syndrome, will she have any pain during intercourse? Possibly. Will she have spotting? No, she wouldn't have spotting. Let's go C. Okay. It is cystitis. No, it cannot be cystitis. So, this patient, she has postcoital spotting. So after sex, she has bleeding. How, like, you gotta have something inside the uterus or inside the vagina in order to have this symptom. This symptom is not associated with a bladder issue, you know? Okay. The genitourinary syndrome of menopause refers to a constellation of symptoms and signs that occur as a result of changes in the genitourinary syndrome caused by hypoestrogenemia. Common symptoms can include urinary frequency, dysuria, dyspareunia, postcoital spotting. Signs include frequent urinary tract infection, vaginal atrophy, mucosal pallor, decreased elasticity. Okay. The 67-year-old patient, dysuria, urinary frequency, dyspareunia, postcoital spotting. Her physical examination is notable for labial result, whatever, blah, 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 blah. Analysis pyuria, hematritic, consistent with UTI. Genitourinary syndrome of menopause. Okay, so basically she has a UTI, right? That's why you have pyuria here. That's why I have pyuria. Recurrent urinary tract infections. Okay, petechiae. Why does she have petechiae? Maybe because of trauma? Huh. So I guess the dyspareunia is just because it is associated with platelets, I think. What is it, cystitis? Interstitial cystitis. So that means like the wall is okay, so genitourinary syndrome of menopause. Right. Which of the following is the best next step? On physical exam, Okay, so this is placental abruption. Okay, she has petechiae. I mean, not necessarily. So skin petechiae, yeah, it's associated with low platelets for sure. Okay, so she has placental abruption. Ultrasound shows the presence of hyper. Okay, her blood type is O Rh positive. Rh positive. Hemoglobin is 10. Fetal blood assay. Which is the following next steps? I mean, you're not gonna give him ROGAM. She's Rh positive, so no ROGAM. Cesarean. Is she stable? It's okay. She's stable. Blood pressure 140. No need for cesarean. I guess it's nifedipine. No, I think she has placental abruption, bro. Hmm. Okay, Kleyer-Hauer-Betke test is just an indication that there was mixing of blood, of fetal blood, with the baby's blood. That's it. Okay, I'll just use what I learned. All right. It's probably either A or B. I don't even know what that is. Okay, I'll pick anything. Okay. Why would you? Okay, that's so weird, bro. Why would you give nifedipine to an placental abruption? Okay, let's see if I was right eliminating E and D. Emergency cesarean delivery is recommended in the case of unstable mother. Okay, yeah, she was stable, so we didn't need that. It is considered the best alternative when the rapid control of bleeding is necessary due to maternal hemodynamic stability. All right. D is indicated for H negative patients. She's already H positive, so we didn't need that. Okay, I eliminated this and this right. This one, no. Okay. Hmm. Okay. I mean, that makes sense. She has very like bad contractions, and contraction will cause the vicious cycle of placenta. Placenta separating even more, so that's a bad thing. Okay. So what is A and B? I don't know. Carbetocin, Carbetocin and carboprost tromethamine are both urotonic drugs indicated for tamponade for the management of postpartum hemorrhage, as they help in the prevention of uterine atony and hemorrhage. Oh, okay. So these are this is a prostaglandin, and this is carbetocin is just oxytocin. This is oxytocin, and this is all right. Yeah, makes sense. Okay, so I guess we gotta give tocolysis to women with placental abruption. Which of the following is the most likely diagnosis? All right, let's see. Um. Okay. Yeah, that's an easy one. Okay, she has infection. Okay, the incision is fine. I think the uterus is fine too. So what is the cause of her feeling hot and no energy? Are you guys not... You don't want to share? You can share, guys. Maybe the left like retain products of conception or something. Yeah. Okay, let's treat for retained products of conception. So I think it'll be... Alright, so either this or this. You don't use metronidazole. This is not like a whatever. You don't use metronidazole. Clindamycin, yeah. Yeah, I think it's clindamycin, gentamicin, no. I'm not really sure though. Let's go with this. Oh god, I was right. That's cool. Okay, clindamycin, metronidazole, and metronidazole have good activity against anaerobic organisms, but do not cover gram-negative. Additionally, metronidazole is generally avoided, if possible, during lactation because it's secreted in breast milk. Whatever, I don't care. It's not used here right now, I'm sure. So clindamycin is used for anaerobic organisms. Gentamicin is used for gram-negative. But there is no need of using ampicillin because this covers gram-positive bacteria. So this is not... Okay. Postpartum endometritis. Okay, I haven't thought of that. I thought it's products of conception. No sound? What do you mean no sound? Pretty sure there's sound. Can you guys let me know? Is there no sound? There is sound, but it's very like low. Okay, one sec. Bro, you're still here? Damn, bro. Okay, this guy's an architect. This guy's an architect, guys. He's not a medical student. Okay, so all right. Okay, clindamycin, gentamicin. All right, postpartum endometritis. Let's move on. Which of the following is the most appropriate contraception for this patient at this time? All right, let's see. So 31 nulliparous woman. She's worried she might be pregnant. She had intercourse 1 day ago with her boyfriend and the condom broke. Her menstrual cycle was 2 weeks ago. Her period was 2 weeks ago. The patient has been in monogamous relationship with her boyfriend for the past yeah, of course. She has used condoms exclusively for pregnancy prevention and is interested in second form of contraception. She takes sumatriptan as needed for migraines with auras. Okay, if she has migraines with auras, you can't give her anything with estrogen. So you can give her combination OCPs. You can give her I mean, progesterone is fine. Hormonal contraceptive vaginal ring. I think that's also estrogen. I'm not sure. Let's leave it here. A bimanual examination is normal. Urine pregnancy test is negative. Which of the following is the appropriate contraception for this patient this time? Okay. Alright, so if you cannot give her combined oral contraceptives, you just can give her progesterone pill. Okay? You can just give her estrogen progesterone pill. Okay, she's worried she might be pregnant, so she doesn't want to be pregnant. So you gotta give her the most effective form of contraception, which is IUDs. Okay, so I think it's just gonna be this. Right, let's see. Okay, I was right about IDs, but I wasn't right about which one, copper or levonorgestrel. Okay, hormonal combination contraceptive, etonorgestrel. Why copper though? Okay, LARC or long-acting reversible contraception provides the safest, most effective reversible contraception available. Types of LARC include etonorgestrel, subcutaneous implant, IUDs. Copper IUDs can be used for emergency contraception. Okay, I didn't know that. So yeah, that makes sense. If she had an intercourse 1 day, she would be like copper IUDs would be helpful for that. Okay, that's a new information to me. Okay, copper IUDs cause intrauterine foreign body inflammatory reaction, which leads to the production of cytotoxic peptides, impairing the motility and function of sperm and leading to sperm phagocytosis. Copper containing IUDs, unlikely with norgestrel, can be used for emergency contraception. Placement of a copper IUD within 120 hours of unprotected intercourse is associated with a pregnancy rate of less than 0.1%. After being used for emergency contraception, the copper-containing IUD can be left in utero for up to 12 years. Holy shit. 12 years. IUDs are appropriate for nulliparous, multiparous women and are safe in adolescents and in perimenopausal. Okay, let's see if D is wrong though. Let's see if G is wrong. The hormonal contraceptive vaginal ring is an estrogen and progesterone. Okay, that was right. So you can give her that. That is also estrogen containing. Okay, we eliminated that. We just picked copper because of the emergency. Okay, let's see the steps here. Okay, that makes sense. Alright, which of the following complications is this patient at most risk for? So let's see. Which of the following complications is this patient at most risk for? Okay, let's see. Monochorionic diamniotic. Yeah, I think twin transfusion. Okay, حاضر. Conjoint twins. Okay. Monochorionic diamniotic can be diagnosed by ultrasound showing a thin intertwined membrane meeting the placenta at 90 degrees. The T sign. Okay. Lambda sign. Lambda sign and T sign. How does lambda? What is lambda? Okay, let's see. So how many questions I got wrong here? 1, 2, 3. I got 7, so 70%. That's pretty good. Which of the following is the best next step in management of this patient? Let's see. Physical examination shows acne, hirsutism, dark velvety patches of skin around her neck and armpits. So that's acanthosis nigricans, well-irrigated vagina, and no cervical adnexal mass or tenderness. High testosterone, hyperlactin. Okay, so this is PCOS. All right, what's the next best step in management? I think oral contraceptive pills. Oh, we have to confirm the diagnosis first. So I think, which is the best next step? All right, so she has hyperandrogenism. and she has like infertility, I think we're just gonna do a transvaginal ultrasound. I suspected that, I swear to God. Okay, I gotta know these criteria. Rotterdam criteria. Rotterdam. Rotterdam criteria. Rotterdam criteria. Diagnosis of PCOS. PCOS. Diagnosis of PCOS. Let's see the. Okay, so 2 out of 3. 2 out of 3. We have oligomenorrhea. Oligomenorrhea and anovulation, or anovulation. Oligomenorrhea, anovulation. Clinical oligomenorrhea and anovulation, clinical and or biochemical signs. Oligomenorrhea and ovulation, clinical or biochemical signs of hyperandrogenism and PCOS, or sorry, PCO, polycystic ovaries, on ultrasound, on transvaginal ultrasound. Okay, so answer E would be just overkill, right? Because we already have oligomenorrhea. She's complaining of irregular menses. She has infertility and ovulation. Her menstrual period occurs every 10 to 12 weeks. 10 to 12. It's very irregular. Let me just make sure, what is oligomenorrhea? Infrequent periods. That's exactly what she's complaining about here. So oligomenorrhea or anovulation. Her last menstrual period was 3 weeks ago. Her body mass index is high. She's obese. Okay, so oligomenorrhea, anovulation, clinical or biochemical signs of hyperandrogenism, polycystic ovaries on transvaginal ultrasound. Clinical and or, so if she has just clinically, that's still 2 out of 3. There's still a diagnosis, so you gotta treat it right away. Lifestyle modifications targeted towards weight loss. So 2 out of 3. So let's say again. So oligomenorrhea. Okay, you gotta also eliminate like other causes of irregular menses. So like HCG, if she's pregnant, or like has whatever, prolactin, which inhibits the GnRH, TSH, if she has hypothyroidism, FSH, early morning 17-hydroxyprogesterone. So okay, let's move on. Okay, which of the following is the most appropriate step to deliver the infant? Okay, let's see. Digital vaginal examination shows the head to be occiput anterior. Occiput anterior. And +3 station. Okay, let's see what's the problem here. Speculum examination, no lesions, membrane rupture. Holy shit. Oh, okay. So category 3 is actually like you deliver the baby, but it doesn't matter if he's like +3 station. So we can use the forceps like assisted vaginal delivery. Because like, look, he's +3 station. He's like almost out. Look. +3 is right here, so it's almost out. Just use the forceps to remove him. Okay, once again, I have to understand this part. So shortly after pushing, the fetal heart rate drops to baseline of 50 per minute. Okay, what is the normal fetal heart rate? The average fetal heart rate is between 110 and 160. Okay, so it dropped to 50 per minute. 110 to 160. It dropped to 50 per minute with absent variability and no response over 5 minutes, even though we changed position and did everything we could. Discontinuing oxytocin, assessment of hypotension. This patient is 10 centimeters dilated and +3 station and candidate for operative vaginal delivery, which can minimize the risk for fetal hypoxic damage and avoid the maternal morbidity associated with cesarean delivery. Okay. Vacuum and forceps. Cephalohematoma. Okay, so vacuum versus forceps vaginal delivery. Vacuum versus forceps vaginal delivery. So vacuum, don't do it less than 34 weeks. So don't do it less than 34 weeks because of risk of cephalohematoma. Forceps, it's fine. Okay, category 3. I actually gotta learn these categories. Management of category. Okay, fetal heart rate tracings. If I watch the video explaining it to me, I'm gonna be very good. I'm gonna solve a lot of questions right, because this is this is my main weakness here. So let me write that down. So fetal heart rate tracing. I need to understand what the hell is that. Okay, fetal heart rate tracing. So category 3, let's just learn this part here. So if it dropped to a baseline of 50 and no response over 5 minutes despite positions changes, that's category 3. Just want to say the categories here. Fetal heart rate tracing categories. Okay, this includes all the following: baseline 110 to 160, baseline FH variability moderate, acceleration present or absent, late or variable decelerations absent, early decelerations present. Okay, let's see. Category 1, no acidemia. Risk of acidemia. Okay, what the hell is that? Okay, see, category 3 is just prepare for delivery, intrauterine resuscitative measures, which is basically repositioning that we just talked about, and evaluation of hypertension. Okay, category 3, everything in between category 1 and 2. So absent variability, that's what's right here. Absent variability. Okay. Baseline bradycardia, like we said, so 50 per minute, right? Sinusoidal wave pattern. I saw that in the question too. So if we have sinusoidal wave pattern, that's category 3 right away. Let me just look at it actually. Sinusoidal wave pattern, fetal heart rate tracing. Okay, let's see that. Holy, look at that. All right, that is like that's category 3. That indicates acidosis, indicates the fetus is gonna die. That's very bad. Recurrent late decelerations, recurrent variable decelerations. All right, so this is category 3. All right. So this part I actually like solved it properly. Like I understood that this is severe and you should deliver the baby, but I failed to identify which part of delivery am I gonna use. Am I gonna use forceps assisted or cesarean delivery? So cesarean delivery is another thing I'm very weak at. So I need to identify what is the C-section indications, when to use C-section. Okay, so management of category 3 fetal heart rate tracing. Vacuum is avoided less than 34. So we have vacuum here, right? No, we don't. Okay. All right, that's fine. Let's move on. Which of the following? I'm gonna reach question 20. I'm gonna go eat or get the food here to eat. Which of the following is the most likely sequela associated with this patient's current condition? So a urine pregnancy test is negative by manual. Okay. Temperature is high. Abdominal tenderness. Multiple sexual partners. She's a hoe. Which of the following is the most likely sequela associated with this patient's current condition? Yeah, she has PID. That's the easy one. Which of the following is the most appropriate next step in management? Oh, nice. Okay, so we have another example of... Okay, I'm gonna get this right. 2 hours later, the fetal heart rate tracing has a baseline of 150 with minimal variability, no accelerations, and gradual decelerations to 140 per minute that occur after each contraction. So this is category 2, I guess, if I'm not wrong. Okay. Hmm. Hmm. I think that's category 2. That's minimal variability. Okay, I'm gonna get some food.
I've lost $100 million over my career, and in this video, I'm gonna break down every single one of my mistakes so you don't have to. My first big loss was crypto, and I'm gonna be ordering these roughly lowest to most amount of money. At the very end, I'll give you the big kahuna, the one that I lost absolutely a shitload on, that you'll probably be able to learn the most from. In 2017, a buddy of mine was like, hey man, you should buy this stuff called Ethereum. It was $100. I set up the account, I put $1 million in, and like right before I'm about to click purchase at $100, it like went down to like 93, and I was like, I don't know about this. And so I decided not to pull the trigger. Long story short, it then, 30x from there or whatever it was. This next time around, a few years later, it had been going like this. And then right here, Bitcoin was at $60,000. Ethereum was really high too. I called my buddy up, not the same guy, different buddy. And I was like, hey man, I'm gonna get in on this. And he was like, I'll put $1 million in if you do. And I was like, fine. So we put $1 million in, and then lost 500 grand in a matter of weeks. But there's two things that I think were good reminders for me from this whole experience. The first is that me making $1 million bet at the time was not a huge percentage of my income or my net worth, and I made more than that every month anyways. I didn't plan on having this be how I made money. I made money doing stuff that are fundamental business things, and then I basically
It's fine, bro. ولا صوت باين يعني ولا؟
made a bet or a gamble, which realistically, it was just gambling. The second big point was that Warren Buffett and Charlie Munger talk about your sphere of competence. Business is very much within that. Marketing, sales, acquisition, pricing, product, those are the things that I'm very good at. Now, outside of this is probably real estate and crypto and a bunch of other things that other people do and have spent lots of time developing their skill set. Those people should do those things. I have no idea. And I have just noticed the further away I get from my core, the more money I lose. And the closer I am to the core of what I'm good at, the more money I make. I will give you a little tidbit that a big point was that Warren Buffett and Charlie Munger talk about your sphere of competence. Business is very much within that. Marketing, sales, acquisition, pricing, product, those are the things that I'm very good at. Now, outside of this is probably real estate and crypto and a bunch of other things that other people do and have spent lots of time developing their skill set. Those people should do those things. I have no idea. And I have just noticed the further away I get from my core, the more money I lose. And the closer I am to the core of what I'm good at, the more money I make. I will give you a little tidbit that a mentor gave to me. If you know how to create wealth, just create wealth. Don't fuck with investing if you know how to make money. And he gave that to me as advice, and I try to remember that as like, what am I good at? And so I think it's important to think about what are the themes that are gonna be around these mistakes, because you're hopefully not gonna repeat the mistake. I'd rather you just get the lesson without the scar, right? And so number one, out of my sphere of competence. Number two, I latched on to FOMO. I saw these people, I was like, man, I would like to make quick, fast, easy money too, right? When everyone thinks something is a good idea, it's usually a bad idea. Whenever you feel that FOMO, I've now learned, pause. So the second big mistake I had was in real estate. And you'll notice there's multiple big mistakes that I will make in real estate over my career, and hopefully I stop making them. This one was actually my first ever real estate investment. So Layla and I have been making a ton of money in gym lunch for a few years now. I think at the time we probably had, I want to say like 20 million bucks in cash. So a buddy of mine's like, hey, I've got this guy. He sells houses in Ohio, because houses in Ohio are actually really cheap. When I got on the phone with the guy, and he said, yeah, I buy them for 30, I fix them for 10 grand, so I have 40,000, and then I flip it to you for 50. So I make 10 on the spread. He's like, that's my business model. I just sell a lot of them. I was like, okay, that's cool. He's like, well, do you want to buy 5? Do you want to buy 10? What do you want to buy? And this is from a lesson that I had learned earlier on less money. I was like, why don't I dip my toe in? Like, let's not lose a shitload of money if this doesn't work. But I said, why don't I just buy one of these houses and see what happens? It turned out that the house was not, in fact, a 3-bedroom. It was actually a 2-bedroom house. And the 3rd bedroom was actually in a closet that they had put a mattress into. The house did not actually have electricity. They were running it from the neighbor's house illegally. The driveway was so in shambles that the people couldn't actually park on it. So tenants couldn't park there. Fixing the driveway on its own was like $7,000. Now for a house that costs $50,000, that's a huge chunk of what you put into as an investment. Now remember, I'm trying to get like $6,000 a year. A friend of mine who is in real estate, different friend, looked up the county records or whatever and found out that the guy who had sold it to me actually bought the house for $19,000 and had put no money into the house. And so his business model was buy it for 19, flip it to 50 to people who don't know any better. That was me. And the tenant's paying $700 a month now. All right, so that was what we were able to rent this place for. Now, $700 a month doesn't cover the driveway that I had to repair. It doesn't cover the electricity that I had to actually run from scratch into this thing to make it livable. And honestly, really kind tenants. They were like, hey, we think, it'd be nice if we could have our own electricity. And like, of course they fucking should. I didn't know, because I was buying it out of state. What did I have to do? Because it was unlivable. I had to put them up in a hotel. Well, we had to basically make this place livable. And so that took like 30 days. This family is in a hotel that I'm paying for this whole time as the landlord, selling the house with the tenant in it, I think for $20,000 because I was like, just get rid of this fucking thing. But the thing that I lost beyond just the $30 or $40 or $50,000 I lost in the deal was the amount of time, effort, and energy and emails and phone calls that went back and forth about this bullshit thing. And for context, at the time, I'm making $50,000 a day in profit. I was like, just fucking get this out of my life. What a mistake. So anyways, I called the guy up who sold me the house. And I was like, dude, like, what the fuck? And basically he stopped responding to my attempts to reach out to him because it was apparent what he had done. And I basically was like, I just want to let you know I'm really grateful that you taught me this lesson for so cheap. And he, being the scumbag that he was, said, you're welcome. He very much was aware of the fact that he was totally running a scam. Let me walk you through some of the lessons that I got from this. So number one is that if it's too good to be true, it usually is. Now he was telling me about 25% plus cash on cash returns, right? I called a buddy of mine who owns $1 billion fund, and I was like, hey, what do you think about this thing? He was like, this doesn't make sense. He's like, because if he really was doing that, he should just own all the houses. Like, why would he sell these houses? And I was like, nah, man, you're just not a believer. Too good to be true. All right, it usually is. And the thing is the hard part about this one's really deceptive, is that if you're in early on something, sometimes it is really good. But the thing that makes it the to be true part is that if no one else is aware of it, there's this double-edged sword of like, am I seeing some opportunity that's gonna close in the marketplace? Or am I just about to get fucking robbed blind? The second thing is you'll see this lovely recurring friend we have here is that I saw my friend making money and I was like, oh man, I should do it. And he was a business guy. And I was like, oh, if he's a business guy, he could do it. I'm a business guy, I could do it. He lost his ass too, which leads me to number 3, which is now, if someone tells me about an opportunity that they're doing for investing, which for me is now a much longer time horizon, I say, how long you been in this deal for? If someone says they've been doing it for less than 2 or 3 years, I don't care. Point 3 is that, what's the hold period? If I'm hearing about something from somebody, they better be doing it for multiple years before I'm gonna even consider it. And so what I would say I do now with these types of things is that, 1, I'll do it with somebody, but I wanna do it with the guy. So that guy who was on the phone with me, selling me the property, what I would do now is to say, I'll buy a property that you buy. And if they don't wanna go in with me, great, then I'm not doing a deal. In the beginning, I was really greedy. I was like, no, I don't want anybody to have the upside. Now, I'm happy to give partners the upside because the more money they make, the more they want to make it with me, and we'll do it together. And I'd rather have a very sure 20% than a really risky 40. And whenever I feel that little tickle in my stomach or the back of my neck where I'm like, ooh, I feel like I'm missing out, I literally just stop. And I say, wait, because every huge amount of money that I've made has never been from any investment. It's been from me seeing an arbitrage opportunity in marketing and sales and seeing that I can acquire a customer for $10 that's worth $1,000 and then saying, great, let's jam as much cash as humanly possible into that. But that takes lots of iterations to get there, and I was there every single step of the way. It doesn't just appear on some spreadsheet showing how rich I'm gonna get. So mistake number 2, my little house in Ohio for $50,000. That taught me lessons far more valuable that have saved me way more than $50,000 over the rest of my investing career. So $50,000 goes, survey says, goodbye. So my third lovely mistake that I had was terrible partners. Now I'm gonna go through a few of these and I'm gonna ladder up to the worst partnership I had. The first partnerships I made because I was insecure. I made them because I didn't think I could do it on my own. I just partnered with people that I thought would know more than me just because they were there, more or less. And this is not any disrespect to those people. It was my mistake, not theirs. I have had 9 failed partnerships in my entire life before I started making money. 9 different people that I was partnered with. I'm gonna give you the nitty gritty of every lesson I learned from all of them. So the first partner that I ever took on was an advisor told me, hey, you should partner with this guy to start a gym. All right, my very first gym. And he said, he's already got a gym in the neighborhood you want to be in. You can start with his clientele base and just go into a bigger gym and come together. And I was like, okay, that sounds good. And he's like, yeah, you guys both have the exact same skill set and you have in the exact same business. You guys should just split it. And then I will take 10% for putting the deal together. So you'll be 45, he'll be 45, and I'll be 10 for advising and putting this whole thing together. And we both said, sure. Now, guess what? The worst way to start a business partnership is you both have the exact same skill sets and you both bring the exact same thing to the table. We're both bringing work and very little capital to the table where we have the same business that we're trying to do. And guess what most people do when they start a business? Exactly that. So, lesson number 1 of partnerships, they have to have something you don't. So they either have to have time you don't, they gotta have money you don't, or they gotta have skills you don't. That's it. If they don't have one of those 3 things, one of you isn't needed. All right, lesson number 1, they gotta have something you don't. Lesson number 2, you lose the most equity day 1. So most people are so anal about how they wanna sell their company for this amount of money and blah, 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 blah. They're thinking about their equity. But day 1, they lop half off and give it to somebody. They lop 2/3 off and give 1/3 here and 1/3 here because they've got 3 buddies. And they say, hey, well, there's 3 of us. Let's cut the pie into thirds and we'll go into business together. Doesn't work that way because oftentimes the economic contribution is not equitable. If you look at time, money, skill between all the people that are going to get into business together, if you have more than one of those and they have more than one of those, well, how much is each person contributing? Now, part of that comes down to negotiation, being really honest about it. But people want to avoid these hard conversations early on because they're like, well,
Did I open some cryptocurrency ad? No, bro. This guy's a successful businessman. I'm watching him for a while.
if it works out, we make a lot of money, it's not gonna matter. I fucking promise you, the more money you make, the more it's gonna fucking matter.
Okay. I'm done now. I'm done eating. Let's grind. Which of the following arterial gas most likely present in this patient? Okay, this is probably hydrated deform more. Okay, so 3 months. So first trimester is like 13 weeks. Just saying, just above the pubic symphysis. What is that? Is that a ectopic pregnancy or what? Oh wait, sorry. Yeah, 12-week intrauterine pregnancy. Oh, okay. So just a pregnant female. What is the what is the pH? That's it. That was the blood gas. I haven't talked about pH. But I guess she has dyspnea, so she's getting rid of the carbon dioxide. So maybe something like that. Probably this. Okay, wow. Holy, I was right. Okay, physiologic dyspnea of pregnancy. Nice. Physiologic dyspnea of pregnancy is caused by high progesterone levels in pregnancy, leading to increased respiratory drive. Okay, interesting. Which of the following is the most likely diagnosis? How are you, Yusuf? How's it going, man? What are you doing these days? Ultrasound, 4 centimeter heterogeneous mass. Okay, the food is actually killing me. Bimanual examination shows ten-week size mobile uterus and bilateral adnexal mass. Okay, these are fecal gene cyst. Fuck that shit. I mean, yeah, there is no history of in vitro fertilization. I'm in Indianapolis now. How is it? What are you doing these days? Damn, the delay is actually... It's a lot of delay here. Delay here. Yeah, there's a lot of delay. Delay here. Yeah, there's a lot of delay. Damn. How's going with you now? I mean, I feel better about the obstetrics for sure. But the problem is Kaplan is wasting a lot of time on on stupid shit. So I haven't gotten even to the things that they ask about in the questions. I probably should have just went to the topics that are high yield, or that they ask about in the question, not watch the entire series. But it is what it is. I already started, so I'm gonna finish it. Yeah, that's just issue. Yeah, for sure. Damn, bro. That's an easy question. Shouldn't have gotten that wrong. I'm not focused. Just 8. And okay, which of the following is the best next step in management? Glucose negative, protein negative. Why don't use Prozac beyond for step 2? It's gonna be copyrighted. I can't just watch it here on stream. I'll have to watch it like outside. And I think Kaplan's pretty good actually. Very high yield. I mean not high yield. I mean like comprehensive. Explains things well. So the phone is the best next step in management. اه اه let's know phone is the best next step. Phone to the physician. Okay, what's the question here? Sorry. Color yellow, glucose. Okay, physical English. Okay, that is positive. Is that the green? What is that, bro? I mean, you can't give her anything other than insulin anyway. So, what is her BMI? Yeah, so she has a positive gestational diabetes. Oh, actually, my face is like hiding the answer choices. Wait. Yeah. The hell's that? Okay, basically pushing. Holy shit, bro. Imagine, like, look how they're describing pushing. Crocodile anemometry shows no contraction. Oxytocin or what? Oh, she's 14 weeks. Okay, huh. This is cervical insufficiency. So what do we do? Do we do cerclage? I think we do cerclage 18 to 20 weeks, something like that. Wait, cerclage we do it 18 to 20 weeks, right? Okay, more than 14 weeks. We do it more than 14 weeks. Okay, so what do we, I don't know. Okay, between 12 and 14. 12 and 14 weeks. Okay, so fuck that. Which of the following is the most appropriate next step in management? Oh, fetal macrosomia. This guy's heavy. uh, should we do cesarean or should we do? Okay. Speculum examination shows a moderate amount of red mucousy in the vaginal discharge and extruding from the cervix and no active bleeding. Complete blood count shows a hemoglobin of 9.6. I mean, that's reassurance. Yeah, I think reassurance. Locia rubra. Why is that like? Two days. Smells stale. What stale means? No longer fresh. Present to eat. Oh, stale. Like food. Imagine describing vaginal fluid stale. Locia is caused by normal physiological shedding of the superficial. I mean, fine, that's fine, that's fine, that's fine. Okay, which, given the reported past obstetric history, which defines the next step in management, physical examination shows no significant finding of pelvic examination, and a saline fusion are found to be normal. Okay. Yeah, the reported past obstetric history, which defines the most important next step in management. Alright, so let's see. 39. Aborted 3, gravida 4. Recurrent spontaneous abortion. Okay, so we did saline infusion sonohistogram. We should do anticardiolipin. Best history of 1 preterm birth, followed by 3 spontaneous abortion, all before 10 weeks gestation. Yeah. Yeah. Okay, that's easy. So, right. So aneuploidy, translocations, thyroid disease, hyperprolactinemia, PCOS, diabetes, antiphospholipid antibody syndrome, congenital anomalies, leiomyoma, endometrious polyps, whatever. Cool. It involves the most likely diagnosis. Soft pulsating mass in the front of the fetal head. Is that a hematoma? Soft pulsating mass in front of the fetal head. Digital examination shows 8 centimeter faced. Okay. Worsening contractions. Placenta previa. Okay, wait, there is no exsanguation. I think it's just placenta previa. Huh. Yeah, to be honest, it doesn't fit placenta previa perfectly. It doesn't fit vasa previa perfectly. I should have just gotten this question elimination. Such a stupid. That's a stupid question. Fuck that shit. Uh, hmm. Hmm. Okay, makes sense. Oh shit, I forgot that. Yeah, maternal positioning. Do you do anything in your day besides studying? No, bro. I just stay at home. Stay at home, mom. Oh my god. The problem is, I used to go to places like hang out when I had a car, but after my car broke, can't do anything. Undergrad here. What is a good score for these test banks? So, all right. So this is not random. This is not how the exam is gonna be. This is just one subject, which is I'm very weak at. So actually, I'm doing good for a bad subject I have. Like I'm supposed to get most of these wrong because I have no idea about most of these stuff are new to me. But so if you are doing random questions, so from all the subjects, OB-GYN, internal medicine, all this stuff, you're supposed to get like 80%, 90%, which is a good score. Damn, I know this, bro. I just this is category 2. Category 2, right? What is even that? What is that, bro? 10 centimeter dilated. What the hell is that? Which of the following is the most likely diagnosis? Okay, speculum examination shows a closed cervix and a 15 milliliter of clotted blood in the vagina, and blood is seen coming from the cervical os. Okay, 36 weeks. Yeah, placenta previa. This if okay, without even continuing to read, but let me continue. No prenatal care. Okay, so at 8 weeks, if you had an ultrasound, the placenta will be very small. It will not. I don't think you will see it. So, okay, yes. All right, good. So the woman shouldn't have sex if she has placenta previa. That is a contraindication. So that is a contraindication. Sex during pregnancy is normal except in a case of placenta previa. That's why she's bleeding right now. Okay, which of the following is the most appropriate next step? Preconceptual counseling. Bro, what the hell is that? What the hell is that, bro? Shut up. 3.4 milligrams? No way, that's too low. To the following is the most appropriate next step. Bedside ultrasound confirms cephalic presentation. This is good to watch. I've been doing case study questions in my spare time, not from Kaplan but from Merck. Much more fun way to learn. This is good to watch. Yeah, bro. Studying is like studying without questions is very ineffective, very passive. Studying with questions is the most effective way to ace these exams. All right. Which of the following is the most appropriate next step in management? 28-year-old, 40 weeks gestation, comes to the ED because of contractions that started 8 hours ago after clear fluid. All right, so she has ruptured membrane. No temperature. Okay, fetal heart rate tracing, normal. Sterile pooling of clear, okay. Mentum posterior. Shit, that obstetrics garbage. Okay, mentum posterior. Mentum posterior. Is that a good thing or a bad thing? Mentum posterior. I think that's fine. You can just give birth to that, right? Mentum posterior presentation. Yeah, this is stupid. B is stupid. C. Mentum anterior. Yeah, I fucked that up. Mentum anterior, not mentum posterior. How do I memorize it? Mentum anterior. Hmm. From occiput posterior to occiput anterior. The normal is occiput anterior. The normal way to give birth is occiput anterior. So manual rotation is for persistent occiput posterior or transverse, so like this. Okay, let me write that. Still haven't studied this part, but manual rotation for persistent occiput posterior or transverse. So if she has mentum posterior, you have to do cesarean section. If it's mentum posterior, this is cesarean section. Mentum posterior cesarean section. Okay. Which of the following increases the patient's risk for pregnancy loss? Okay, let's see what the hell is that. Yeah, that's an easy one. Yeah. And that's a placental abruption, bro. Through an abortion. Yeah. Oh, that's gonna cause placental abruption. Okay, laboratory testing at this time is most likely to show which of the following. Laboratory testing at this time. Okay, so third trimester, she's having generalized seizures with post-ictal state. She has hypertension, no deficits, deep tendon reflexes are brisk, proteinuria, so this is eclampsia. Bedside ultrasound confirms cephalic presentation. What are the findings? What was the system that came up the most on your exam? Like step 1 exam? I think it was endocrine, I think. Laboratory testing at this time is most likely to show which of the following. Eclampsia. Hypomagnesemia? No hypomagnesemia. Hypercalcemia. Hyperglycemia. She's taking hydroxychloroquine for lupus. Oh wait. Seizure prophylaxis. Oh no. She was treated. Damn. She was treated for that. Oh, okay. That makes sense. That is easy. My bad. I didn't read that she was treated. Seizure prophylaxis. They gave her magnesium sulfate as a treatment, or like for seizure prophylaxis. All right. I mean, these questions I'm losing actually. Like, I don't know. I need Adderall or something. I need to focus. These are easy questions to miss. Okay, whatever. Which of the following is the most appropriate next step in management? 38-year-old, Corvita 2, routine prenatal visit, nifedipine for hypertension, last pregnancy ended with a classical C-section, in vitro presentation. I mean, that's fine. Oh, so she has a risk factor. She has preeclampsia's risk factor. A, biophysical profile. Which one, this or this? Oh, this. mean, she seems fine. She seems fine. No need for that. Induction of labor. She's still 34 weeks. Umbilical artery, Doppler. Okay. Stress test is commonly the initial antepartum fetal surveillance modality performed to detect fetal hypoxia. A negative NST excludes hypoxia. Positive NST requires evaluation. Okay, no accelerations. Oh, okay. Yeah, I got it. This is abnormal. So YC is wrong then. So they have actually looking for the best resources to study step 3 from, and I'm stuck. Question banks. Do your questions. You're done with step 2. You have good foundations. So just do questions. Oh, okay, this patient has hydrops fatalis. What are we gonna do next? Actually cannot focus. can't continue these 3 questions. I have to take a break.